minimally.
Okay. Read ಮಾಡಿದಾಗ ತಿರ್ಗಾ ಡಬಲ್ ಕ್ಲಿಕ್ ಮಾಡಿ ಆಮೇಲೆ ಮ್ಯೂಟ್ ಮಾಡ್ಕೋಬೇಕು ಅಲ್ಲ
ಇದು ಸೈಡಿಗೆ ಹಾಕಿದ್ರೆ ಇಲ್ಲೇ ಬರುತ್ತೆ ಸರ್.
ಓಕೆ ತಿರ್ಗಾ ಮ್ಯೂಟ್ ಆನ್ ಮಾಡಿ ಅವಾಗ ನಂದು ಮ್ಯೂಟ್ ಆಗಲ್ಲ ತಾನೆ?
ಇಲ್ಲ, ಒಂದು ಇದು ಮಾತ್ರ ಮ್ಯೂಟ್ ನೀವೇ ಮಾಡೋದು.
ಗೊತ್ತಾಯ್ತು. Okay, good morning, good afternoon students. Today we learn some prescriptions in respiratory systems. Among these we have 3 prescriptions in respiratory system and 1 prescription from the hormones. You must have all know what are the parts of the prescriptions. We have told you in the first class itself. It contains superscription, inscription, subscription, signature and transcription. Okay, superscription contains the name, age, sex and other details of the patient with doctor's name and his registration number, where the clinic is situated, all these things with the sign of take down RX will be there. In subscription, we are going to give all the parts of the inscription is the body of the prescription. It contains all the drugs what we are going to use. Then signature and subscription with transcriptions. Okay. Now we'll start. The first prescription of today is prescribe for a student suffering from dry cough. So in respiratory system we have 2 types of cough. One is dry cough and another one is wet cough. According to this prescription, we are going to treat the patient with dry cough. Means he is not producing any sputum. The rule in the treatment of cough is you can prescribe the antitussives or cough suppressants in dry cough, whereas it is not allowed in wet cough or the cough which is producing the sputum. So under superscription we have Mr. Vinay. He is aged about 18 years, male. He is residing in 8th Cross, Malleshwaram, Bangalore. The prescription given by a doctor by name Dr. Shruti and her registration number, where she is staying, all these things is there. The drug given here is syrup linctus codeine. Okay, codeine is an antitussive. It is an analog of morphine and it doesn't contain many of the side effects of the morphine. We are going to give syrup linctus codeine in a strength of 15 milligrams in 500. And the order given is send such 1 bottle so that a pharmacist send a bottle of syrup linctus codeine. And the advice to the patient is 1 teaspoon to be taken twice a day for 3 days. And the advice also should be there that it may have some sedative effect, so he should not be allowed to ride a bike or use a heavy machineries. This prescription is only for the dry cough, not for the wet cough. The second one is prescribe a prophylactic treatment for a patient suffering from chronic bronchial asthma. So chronic bronchial asthma is going to come under wet cough. So he will be producing sputum but unable to bring out the sputum. That is the pathophysiology of the asthma. Here the patient is suffering from chronic bronchial asthma. He is an old patient who is already had several attacks of bronchial asthma. So she is a lady of 26 years old. She is residing in Kalyan Nagar, Bangalore. Again, the prescription given by a doctor by name Shruti, and the prescription is given by our hospital, that is Rajarajeshwari Medical College and Hospital. What are the drugs used here? We are going to use bronchodilators, then steroids, anti-inflammatory agents are the main way of treating this bronchial asthma, because the patient will be presenting to you with difficulty in breathing, increased respiratory rate, unable to talk, unable to perform his normal activity, and on examination he will be having tachypnea, tachycardia, and also the wheeze in the respiratory area. So what are we going to do now? The first and foremost is, as he is a chronic patient of chronic bronchial asthma, we can give inhalers. First, we are going to use steroid inhaler, that is budesonide inhaler. The strength is 200 micrograms. This is a meter dose inhaler. So meter dose inhaler is the one which is going to deliver a concerned amount of drug in for a single puff. So this is different from a rotahaler. Here the medicaments will be in the gas form, whereas in rotahaler it will be in the capsule in a powdered form. Using of both is different. So to increase the compliance of the patient, or to coordinate the patient's respiration with delivery of the drug, you can use or you can prescribe another instrument which helps in the compliance or increase the compliance of the patient. So budesonide inhaler which you have prescribed is going to deliver 200 micrograms per inhalation. And the advice given to the pharmacist is send such 1 meter dose inhaler, and advice given to the patient is 1 puff to be inhaled once every 12 hours. And after using this, one of the side effects of using budesonide or steroid inhalers, the inhaled drug which is going to be stay or be there in the oral cavity. So you should also give an advice to the patient. He should rinse his mouth after every use, and he should also rinse the mouthpiece of the inhaler. To prevent the side effects like oral candidiasis, he should be advised to rinse his mouth after every use. The another inhaler which you are going to prescribe is salbutamol inhaler, that is beta-2 agonist. It is available in a strength of 100 micrograms. The advice given to the pharmacist is send such 1 meter dose inhaler, so that the advice given to the patient is 2 puffs to be inhaled once as when needed. So you all know, when you prescribe a steroid with a beta-2 agonist, it will increase the action of the beta-2 agonist by increasing the receptor activity. If you prescribe only salbutamol or beta-2 agonist, it may, after long time of use, the receptor activity will be reduced. The action when compared to the previous dose will be not seen. So what you are going to do to prevent this, you are going to use steroid inhalers. Also, it is also going to give anti-inflammatory. So it produces it breaks the chain of inflammation. Thereby, the effect produced by the different cytokines, leukotrienes, all will be subsided by using steroids. At the end, you have to put your signature, and again you have to write your name, your registration number, date. Okay. The third one is prescribed for a woman presenting with status asthmaticus. Students, here I have taken out the superscription. I have presenting you only the inscription because I couldn't able to type the name of the patient and the doctor. So I am presenting to you only the inscription part of the prescription or the body part. So what is status asthmaticus? Asthma is a condition where patient is unable to breathe properly. He will be presenting to you with dyspnea and rales or wheeze. It is due to the release of many inflammatory agents like leukotrienes, all these things, and platelet activating factors. All these things, histamine is going to produce a bronchoconstriction and unable to produce or take out the mucus properly because there will be congestion and there will be production of the mucus will be more. Even then, he is not able to bring out the sputum properly. Then what is the difference is status asthmaticus, where the patient he will be having repeated attacks of acute asthma. So he is unable to reduce his symptoms by using normal inhalers like meter-dose inhalers. So he will be presenting to you with severe tachypnea and respiratory rate. So the idea of treating is we have to give steroids, that is short-acting steroids, hydrocortisone, hemisuccinate, 100 milligram IV bolus stat. So the advice will be given to the pharmacist to give 1 ampule. This 1 ampule will be diluted in a normal saline or injection, water for injection. Then it will be given intravenously in a stat dose. So it will reduce it produces immediate action and it is going to reduce the inflammatory process that is ongoing in the patient. Then the second one is high flow humidified oxygen inhalation via oxygen mask until oxygen saturation reaches above 90%. First, as soon as the patient comes to you, check the oxygen saturation. If it is less than 90%, put him on oxygen either through nasal prongs or through the mask. If you are putting the patient through the nasal prongs, the advisable oxygen limit is 2 to 3 liters. So if you want to increase or if you want to give more than 3 liters, then you have to go for the oxygen mask only. And this oxygen should not be dry oxygen, it should be humidified. So the irritation will be reduced. As soon as the patient reaches 90% of oxygen saturation, either you may continue in the same level or you may reduce the concentration of the solution or oxygen to 2 to 3 liters. The next, what we are going to use is nebulization. Here we are going to use both beta 2 agonist and anticholinergic bronchodilators. Beta 2 agonist is salbutamol in a dose of 2.5 milligrams in a combination of anticholinergics like ipratropium bromide, the dose of that drug is 0.5 milligrams. Usually this will be given through the what you have seen through the nebulizer, which will be run by an electrical current. But what we are going to use here is we are going to use oxygen in place of a nebulizing machine, so that the oxygen saturation should not drop and even the action of the bronchodilation should also be seen. So we are going to use oxygen as a forceful agent. Through this, the liquid which we have given in the container will be used as a nebulizer. This nebulization driven by oxygen every 20 minutes for 1 hour, followed by salbutamol only in 2 hours, once in 2 hours. So the advice given to the pharmacist is send such 3 vials of combination containing drug, that is salbutamol and ipratropium, 3 vials, and 12 vials which contains only salbutamol, that is 5 milligrams. First vial to be inhaled via nebulizer and repeated every 20 minutes for the first hour, followed by nebulization of 1 vial of salbutamol 5 milligrams every 2 hours. To have a ultimate action or to have a good bronchodilation, we are going to use beta-2 agonist with anticholinergics at the first hour, and we are going to repeat in every 20 minutes. After some time, after obtaining a good saturation, after relieving his bronchoconstriction, then you can switch on to the just beta-2 agonist, that is salbutamol. The next drug we are going to give is ringer lactate, that is IV fluid. We have different IV fluids, that is dextrose normal saline, off normal saline, and ringer lactates. Among these, ringer lactates have electrolyte supplements within them. So due to the increased respiratory rate and increased breathing, there may be little electrolyte imbalance. So you are going to give ringer lactates as an infusion. The advice given to the pharmacist is to send 1 such bottle, and this should be infused slowly. Here you are not going to use normal saline or off normal saline or dextrose normal saline, because you don't need to have another way of dyspnea. Okay, this may hamper the cardiac activity also. So you will prevent these IV fluids, whereas you are going to give ringer lactate. It contains sugar with electrolytes. So you are going to supplement the energy required and even the electrolyte that is required to the patient. The last drug is tablet prednisolone, 45 milligrams. First, the drug we have given is injection hydrocortisone, that is short duration, short acting. Whereas prednisolone is a long acting, so you will also start prednisolone so that you can maintain the anti-inflammatory activity that is produced by the hydrocortisone immediately, and to have a sustainable action of that anti-inflammatory action of the steroids, you are going to start tablet prednisolone in a dose of 45 milligrams. Advice given to the pharmacist is send such 10 tablets, 1 tablet to be taken daily early in the morning for 10 days. So depending upon the status of the patient, you may be going to shift either to the ICU or to the general ward. But the nebulization will be continued. Prednisolone will also be continued. According to the oxygen saturation, you may continue the oxygen or you may discontinue the oxygen. If you are going to shift the patient from the emergency to the general ward, there you can use nebulizing machines only. If the attack is not subsiding, if you want to keep the patient under observation, so you can shift the patient to the ICU. There you can observe the patient by ECG monitoring and continuous pulse oximetry. Thereby you can change your protocol of the treatment. Those three prescriptions is from the respiratory system. First one is treatment of dry cough, where you are going to use antitussives, that is a morphine analog or congener, that is codeine. We have different antitussives, nosacapine, dextromethorphan, all these things we can use here to reduce or to suppress the cough activity. This is going to act on the central nervous system, that is cough center. Thereby it will reduce the cough stimulus. But the advice should be given that you should be very careful while riding a bike or using a heavy machineries. The second one is a patient with acute bronchial asthma. You should note that here we are not using a nebulizer or oxygen, IV fluid, or a short-acting steroids. We are here using a bronchodilator, long-acting bronchodilators like salbutamol, and a budesonide steroid inhaler. That too in a meter dose inhaler. You can give either in a meter dose inhaler or through the rotahaler. If you are using steroids, then it is our duty to give an advice to resist the mouth after every use to prevent the complications like oral candidiasis. The last one is chronic bronchial, status asthmaticus. Here we are going to use short-acting corticosteroids like hydrocortisone. So you need to reduce the activity of inflammation as early as possible, and to give a good effect of bronchodilation, you are going to use salbutamol with anticholinergics like ipratropium in first 1 to 2 hours in a gap of every 20 minutes and through oxygen. Then after reduction of the tachypnea or respiratory rate, you can use salbutamol alone. With this, you are going to substitute the patient, are going to give the energy or the needful electrolytes by infusing ringer lactate solution, and also to have sustainable anti-inflammatory action, you are going to start tablet prednisolone in a dose of 45 milligrams. Thereby, we are going to maintain the patient, or these are the three prescriptions under respiratory system. But whenever you are going to be given to write a prescription, you have to write the subscription first, superscription, where you have to write the patient details and doctor details and take those sign. Then you should start writing the body of the prescription, which is also known as inscription, many drugs which you are going to prescribe. Then you should end the prescription by putting your signature and the date. In inscription only, you are going to give the advice to the patient when it should be taken, how it should be taken, whether it should be diluted or to be inhaled or to be given through injection. All these things should be written in the inscription only. This should be presented with a block. Okay, it should not be written in a plain paper. You should put a rectangular box. Within that box, you have to write all these details. The last prescription of the day is complete drug therapy for a patient suffering from diabetic ketoacidosis. You know what is diabetes? Diabetes is a metabolic condition where patient will be presenting you with hyperglycemia, increased glucose in blood and in urine also. There are two types of diabetes, that is type 1 and type 2 diabetes. Banting is the person or a scientist who invented insulin. We have different types of insulin, human insulin, and then animal insulin. Among that, we have actapid, lente, semi-lente, ultra-lente. Then we have newer insulins, delta mever, glargine, all these things. One is according to the nature of the or source, that is human or animal. Then according to the duration of action, then according to the preparations. If you want to increase the duration of the action, you are going to use protamine sulfate and zinc as a substituent. Thereby, we can increase the duration of the action. We have short duration of action like plain insulin. Then long duration, we have lente, ultra lente, all these things. Then we have newer insulins in the treatment of type 1 diabetes. In type 2 diabetes, we have many drugs, biguanides, and sulfonylureas, and other GPP inhibitors. All these things are in the pipeline to be used. So even the complications of diabetes is different in different patients. In type 1 diabetes, the occurrence will be in younger age due to the non-availability of the insulin, or there will be no production of the insulin from the pancreas. So you are going to substitute this unavailability or non-productivity of the insulin by giving the insulin from outside. Whereas in type 2 diabetes, the patient will be having reduced production of insulin, and there will be the regulators will be not acting properly. Insulin receptors will be not acting properly. In these two situations, we are going to prescribe oral hypoglycemic agents. The complications in type 1 diabetes is diabetic ketoacidosis, whereas in type 2 is hyperosmolar coma is the another one. And you may see hypoglycemia in both of the patient. In type 1 also you can see hypoglycemia. In type 2 also you can see hypoglycemia. After knowing what is diabetes, what are the preparations we use, what are the types of diabetes, so we came to know type 1 patients are going to present to you with diabetic ketoacidosis. Here the patient is diabetic and he is in acidosis due to the overproduction of ketone bodies. This is precipitated either by the infection or injury or trauma, anything where the necessity of the insulin is more, but unable to give that properly or maintain the hyperglycemic condition properly. So the glucose level in the body may reach more than 600, and he will shift into the different mode of metabolism. Production of ketone bodies will be increased, and because of that, the patient will be also going to get acidosis. You have a peculiar sign known as Kussmaul sign of breathing, and the smell of the breath will be sweet because of the ketone bodies. How do you treat these patients? These patients will be unconscious, and he will be having tachypnea and acidotic breathing. So our aim is first to reduce the hyperglycemia, which is more than 600. So we have to reduce the glucose concentration in the blood as early as possible. So we are going to use insulin, that is short acting, regular insulin in a dose of 0.1 units per kg. This is given through IV bolus followed by 0.1 units per kg per hour continuous IV infusion. Advice to the pharmacist is to send such 2 vials, one vial to be injected IV bolus and another vial to be injected IV continuously at a rate of 0.1 units per kg per hour. Okay. Here we are not going to use either lente or ultra lente or long acting insulins we are not going to use. We have to reduce the hyperglycemic condition as early as possible, so there will be no further loss of consciousness, further effect on the central nervous system. The next is normal saline infusion. Send such 2 bottles, one bottle to be infused intravenously initially at a rate of 1 liter per hour. The another bottle to be infused intravenously at a rate of 0.5 liters per 4 hours dependent upon the volume status. Here the patient should be put on ECG monitor and pulse oximetry, and you should watch the signs of overload, like he may present you with extra respiratory effort, dyspnea, then oxygen saturation may be reducing. He may develop the signs of failure because of the overload of the fluids. So you should be in a way to maintain the input output chart. Then you should maintain the oxygen saturation. You should regularly watch the ECG and blood pressure of the patient. The next drug we are going to use injection potassium chloride, that is given intravenously in a dose of 10 milliequivalents. The advice to the pharmacist is to send such 1 vial, 10 milliequivalents per hour to be added to normal saline infusion at 4 hours, after 4 hours. So first of all, you are going to infuse 1 bottle in, that is 100 ml, 500 ml fast. Then after 4 hours, you are going to give in a maintenance dose. There you are going to use potassium chloride. This potassium chloride drains the glucose into the cell and helps in the activation of the insulin receptors. So thereby it increases the or decreases the hyperglycemia also, and the patient will be having hypokalemia due to the fluid imbalance. So there will be shifting of the fluid from the extracellular to the intracellular fluid, from the intracellular to the extracellular fluid. So due to this transfer of fluids, patient will be having hypokalemia. It is not due to the loss, it is only due to the shifting of the fluids. So it is our duty to substitute the potassium to the patient, but even you should maintain the dose of the potassium in a standardized or a given protocol way, so that This potassium has a direct action on the heart, so patient may land up in the cardiac arrest. The next is correction of the acidosis. To this, we are going to use sodium bicarbonate. The available is 50 milliequivalent. So the advice given to the patient is send such one vial, 50 milliequivalents to be added to the normal saline if blood pH is less than 7.1. In brief, I would like to tell you we are going to do acid base gas analysis by taking the blood from the arteries like radial artery or femoral artery in a heparin vial, and it will be sent to the biochemistry lab. We have a specific instruments to measure this. Here we are going to use by this heparinated blood, we are going to assess one, the pH of the blood, then carbonate level, that is bicarbonate level, and carbon dioxide level. Depending upon this, you may be classified into acidosis or alkalosis. Again, this acidosis is again classified into respiratory acidosis or metabolic acidosis, and alkalosis is also classified like that only, respiratory alkalosis and metabolic alkalosis. So we are going to use sodium bicarbonate if the patient is having a acid pH that is less than 7.1. Then you are going to infuse 5% glucose in half normal saline IV infusion. So we are not going to use the normal saline for a longer duration of time. So we are going to use after everything is become normal, like hyperglycemic condition, that is more than 600 is going to drop, and our duty is not so that the sugar level in the blood should not be reduced less than 300 milligram. Okay, you should maintain around this level only. You should not allow the sugar level to drop less than 300 milligrams. When you reach this stage and the other, like even you have corrected the fluid imbalance, potassium imbalance, then acidosis, all these things is corrected by using different drugs. Then you are going to use 5% glucose to maintain a glucose level in a range of 300 in these patients, and this 5% glucose is dissolved in half normal saline. Here the idea is one, to maintain the glycemic status, and another one is also to maintain the cardiac status. So if you are going to infuse the normal saline for a longer duration of time, the patient may land up in acute left ventricular failure. Thereby, to prevent this condition, we are going to use half normal saline. Send such one bottle to be infused IV after blood sugar has reached 300 milligram per deciliter and BP and heart rate have been stabilized. So as explaining to you in the first, I have told you that as soon as you noted this patient as labeled this patient is as diabetic ketoacidosis, you have to put the patient in emergency or in ICU with ECG monitoring, with pulse oximetry, regular BP analysis every half an hour or 1 hour. Then you have to assess the heart rate. The other needful procedures like blood analysis, all these things you should follow side by side. This is how you are going to treat the diabetic ketoacidosis. If you have any doubts, you are allowed to chat. You can ask the questions in a chat box given to you. And then I will post you the answers. Thank you.
nó sẽ trên đường làm cột cả Indonesia